Listen now to a talk Peter McCollough had with Dr. Leslie Miller, the Everett Wright Professor of Medicine at the Morsani College of Medicine at the University of South Florida in Tampa, Florida. They cover efficacy of stem cell therapy for cardiovascular disease.
This is part of a debate where Dr. Miller took the protagonist approach, and Les, welcome to ACCEL.
Thank you very much.
Why don't we start out with just a few comments from your vantage point regarding regenerative therapy in general and where it's really being applied in clinical medicine?
Regenerative medicine can be defined as using stem cells and gene therapy primarily to recover or repair damaged tissue, organs, or vessels anywhere in the body. The Institute of Medicine has said it's probably one of the most profound advances is an understanding that the body needs to repair all the time, and there is this inherent ability, and for which stem cells are without a doubt the primary mechanism in which you heal or address any injury over time. So the application of this is in every discipline in medicine today, and I think it's really going to be an important part because we've transitioned from the understanding that acute illness is the biggest health problem to now, without a question, we spend nearly 70% of our U.S. budget and around the world on chronic diseases. So we don't have many therapies that are effective or could really stem the tide of progression or potentially induce regression, and that's what regenerative medicine is designed to try and do.
And your topic is broadly cardiovascular disease, which I guess could mean atherosclerosis, myocardial disease, valvular disease, arrhythmias. Where do you think the best application is?
The greatest experience in regenerative medicine has been in the field of cardiovascular disease because it is the highest cause of death in the world, and so we focus on that. But I think it's important that people understand that what we describe and what we see in this field is applicable to every other discipline in medicine because these are generalized response patterns. It is clearly now being examined very closely in stroke, both acute and chronic stroke, much like acute myocardial infarction and heart failure. Those have been the major areas of ischemia. We've looked at refractory angina, a very big experience in peripheral vascular disease. So it's been targeted a lot at ischemic disease, but I think that we're expanding into non-ischemic heart failure and other disciplines within the whole realm of cardiovascular disease.
And I think another important observation has been the idea that heart muscle cells and cardiomyocytes really have their own natural turnover through aging.
There's no question that the concept of apoptosis is a uniformly accepted biologic phenomenon in the body. It occurs at variable 2 to 4% per year, and estimates range from turning over half to several fold of your whole cardiac population within your lifetime. And so that has to rely on a mechanism in place with cardiac cells to be able to regenerate. We've come a long way in understanding that when we transplant cells, they don't stay very long. We thought, okay, well, they would form this new front wall and they'd be fine. But now we understand that they actually release a lot of trophic substances that turn on the body's native repair. It's there. We just have to understand how to harness it.
Now, are these recovery cells, are they resident in the myocardium or do they come from elsewhere in the body?
There's some evidence that there's a blush from the bone marrow with ever an injury, but again, in chronic disease, there isn't a big inflammatory signal. There's not a big, profound stimulus to bring cells, so we've done primarily exogenous delivery of cells of various types now, but no matter what cell we deliver, we understand that they turn on these resident cells, and they've been identified in heart, brain, kidney, lung. Every organ has what's referred to as a lineage-specific progenitor cell population. They really affect the benefit that's seen.
So let's take the example of heart failure and myocardial disease. What are the leading cell lines that are now being considered in clinical trials?
Without a doubt, the largest experience has been using bone marrow. That was our naive understanding, the only place that you could derive cells. The human embryo has largely been discontinued as a theoretically clinical application for a variety of reasons, but we've really moved into an understanding of the abundance of stem cells in adipose tissue, which is an interesting observation in terms of potentially 100 to 1,000-fold more per gram of tissue in adipose tissue, the number of stem cells, than there are in bone marrow. But what an interesting observation is that with age, we get telomere shortening, and we know that the number of cells in the bone marrow and the functional capacity goes down with each decade of life. And so we've kind of gone the opposite direction. There's a lot of work going on using umbilical cords or placenta or even amniotic fluid, because those are the most robust cells in vitro, and no reason we can't derive specific cell types, but that is a very important source. We've moved endometrial tissue, profoundly proangiogenic. That's a stem cell. Keeps renewing. It meets that definition. So we've really expanded an amazing repertoire of sources, and conversely, one of the most important changes in understanding is that we always thought the safest and only type of cell you could get was your own, an autologous cell. But we've identified a mesenchymal type stem cell that's in fat and in bone marrow and in a variety of circumstances, which has the unique ability to not express antigens you'd recognize. And now we can give that, which allows us to use a 20-year-old donor and have an off-the-shelf preparation. So it's being applied to every area of medicine today, and all of cardiovascular applications are really examining this allogeneic mesenchymal stem cell.
Wow, that's very futuristic. Now, we've seen delivery methods from directly injecting them into the myocardium to injecting down the coronaries and then, peripheral intravenous. What's your view on the mode of delivery and how the cells actually home into the myocardium and stay there?
It's an important idea. We understood the importance of homing a signal of inflammation to draw the cells to the area of injury. And when we were doing acute myocardial infarction, you could just do a flush down the coronary and the cells would gravitate back to that. Similarly, you can even give them intravenously in a heart attack and they'll go where there is inflammation. But as I suggested, that's not very helpful for people with chronic disease. So we certainly developed new catheters to do intramyocardial, endomyocardial delivery and put the cells right in the muscle wall. The latest advance in that area is examining retrograde coronary sinus delivery, in which you can inflate a balloon to occlude the coronary sinus and inject the cells retrograde, and now you get diffuse uptake throughout the myocardium, and we think that would be, it's cheaper, easier, and when we think about global application of these therapies, that would make this a much more cost-effective and easier to achieve endpoint.
Do you think there's any hope for intravenous infusions and just having the cells home into the myocardium?
It sure would be nice if we found that. We've looked at methodologies such as mannitol in the brain, and it opens up the permeability of the endothelium for a brief period of time and allows an influx of cells over just giving them intravenously. But I think we found that you really need a homing signal. In peripheral vascular disease, there's chronic inflammation there, but chronic heart failure we don't think has much of a signal. So I think the big message is we have so many new methods. We have so many new cells and new sources. We're not monolithic anymore. It's not a bone marrow mononuclear down the coronary. We can really tailor our therapy to the need of the particular patient.
Now, there's a lot of excitement about patients who receive left ventricular assist devices being candidates potentially for stem cell therapy. Can you say a few words?
Well, there's an NIH trial that began to examine this, again, using that allogeneic mesenchymal stem cell, because it's the ideal platform. These are patients awaiting a heart transplant. They had end-stage shock type heart failure and had an assist device put in. That allows the ventricle to be completely decompressed. But here's the concept of adjunctive. It's not to replace the device. It's not to replace medical therapy. But you have an ability to inject cells and see if you can't allow them to regenerate cardiac muscle and vasculature to be able to get those people back off the device. That's the holy grail of LVAD therapy. There's a new second phase trial just starting now from the NIH, but I think you'll see other types of cells delivered in that circumstance. And most importantly, one of the new advances coming in the field is multiple dosing. Everything that's been written in cardiovascular disease has been completely on a single administration. And now we understand that why couldn't we come back, particularly retrograde delivery, and now be able to achieve every 3 months to 6 months another course of therapy, much like you would do in any other discipline like oncology, and achieve a substantial benefit.
My final question for you is, are you confident that we have the imaging type of parameters to identify a signal of benefit or harm now in the clinical trials underway?
Let me respond to the second part of that. I think one of the most important parts of this therapy is the safety. Obviously, if you're using autologous cells, there's absolutely no adverse effects whatsoever. The cells are washed and subfractions given back to you. These allogeneic cells are now into a 1,700 patient trial worldwide. I think that really gives evidence to the perceived safety, and there's no adverse reaction to that. So we don't have safety as an issue. I think we've been using several surrogates like ejection fraction, and that's a reasonable endpoint, but we're looking at remodeling. We're looking at a variety of new markers that will tell us the efficacy.
Well, thanks. This has been a terrific overview of stem cell or regenerative therapy for cardiovascular disease, and it sounds like you have a strong position in your debate as the protagonist. And I want to thank you for joining us on ACCEL.
I enjoyed it. Thank you for asking me.